Okay. So we will go for an hour, take a break, and then finish for the next one. So this section, there's, I think, 62 slides, so this should fit in an hour, and we shouldn't be as rushed as we were last week with some of the introduction information. So all really valuable, but again, I apologize if I went fast. So let me just get to progressing. So the outcomes, what I hope that you get from tonight's session is recognize the major disabilities that use assistive technology, identify particular features of assistive technology that can help certain impairments, and identify etiologies and pathologies involved in disabilities that can benefit from assistive technology. So as we said Tuesday, that everyone is very individual, and we are making some generalizations to try and reflect the broadband of some of these categories. So in part 2, we are going to go over neurological disorders that are more degenerative in nature, and then we're going to go over muscular disorders. We're also going to look at some orthopedic disorders and go into how those present. So multiple sclerosis. The definition of multiple sclerosis is an inflammatory disease of the central nervous system characterized by 2 or more lesions separated in time and space. So what happens in multiple sclerosis is the myelin sheath, which is this picture right here. It's a single cell whose membrane wraps around the axon. And the axon is what carries the nerve signals for transmission. I see Leah has paused. I'm going to check in with Heather. Are we okay? Heather, can you hear me?
I can.
Okay,
You're all good on my end. Yep.
Okay. So back to the multiple sclerosis. So the axon is where the nerve signals travel. So when the nerve signals travel down the axon, if the myelin sheath is destroyed, then it prevents the nerve signal from getting down, and that's where you have the impairments. So with the destroying of the membrane is where you have inflammation and scarring. Characteristics of multiple sclerosis is it is a progressive neurologic condition, so the person's presentation will change over time. We usually see adult onset. There is about the earliest generalized diagnosis is 20, and it could be diagnosed up to 50 years of age. Typically, before and after those ages, we don't see multiple sclerosis. It is about 1 million people in the US over 18 have been diagnosed with MS. This disease is higher in females. So we saw that the spinal cord injuries were higher in males. But the cause of the demyelinization in the central nervous system is the myelinous loss. It leaves scar tissue. That scar tissue is the sclerosis. And then the damaged areas are the lesions or the plaque. The progression is very different in each individual. The fatigue and heat leads to an exacerbation and loss of function. So what you can see is that people maybe in the summertime will stay inside more. They will avoid like swimming in hot water. A lot of indoor pools have warm water pools or cool water pools. And so people with MS will stay away from the warm water pools. You'll see cooling vests. You'll see people use a lot of strategies to try and keep their body under control and keep it cool. Usually somebody has it throughout their lifespan. It's a long disease, and you see progressive changes very, very slowly.
All right, I'm letting Teresa know the audio is not working at the moment, so give us a second to get it fixed. Teresa is going to go ahead and call in. Oh, there you are. Perfect. Yep.
Aldrich says she can hear me.
I think we lost you again.
Can you hear me now?
We can hear you now.
Okay, can you see me?
Nope, we can't see you.
Can you see the slide?
We see the slides.
Okay, you don't need to see me then, I guess. Cooling vests are very common with people with multiple sclerosis, and acceptance of assistive technology may be an issue. Sometimes it's an issue because of their needs are so slow, they're not ready for it. But there's also a cognitive component to the multiple sclerosis that sometimes interferes with some of the problem solving. With people with multiple sclerosis, just using versatile and adaptable equipment due to the unstable and unpredictable nature of it, of the disease. They really don't know what causes it. As I said, it's an immune-mediated process, so there's a lot of information that you're seeing across the board with autoimmune diseases. Some people will blame the environment. Some people will blame foods. Some people will think it's genetic, but definitely, you know, you can't fight if there's a genetic string of it, but it's really an autoimmune disease. The interesting thing is they find that it's more common in people living further from the equator. No idea why that is, but that's been studied. And as I said, there is probably a genetic connection, but they haven't really been able to really solidify what that is. So the types of multiple sclerosis you'll hear is relapsing, remitting, secondary progressive, primary progressive, and progressive relapsing. The most common is relapsing remitting. And so what happens is if somebody has an exacerbation and then things get better, and then they have an exacerbation, and then you kind of see the different patterns. Heather, I see a lot of hands up, so I'm going to keep going and let you tell me when we should stop. Is that okay?
That works.
Okay. So one example of somebody that presents, they may have a weakness, paralysis, they may have spasticity, they may have ataxia. So ataxia is the smooth movement and the coordinated movements, which the following one is uncoordinated. They could have very poor balance, which leads to poor gait. Sometimes I don't see pain a ton. I'm just giving you my clinical experience, but you know, with any of these, you can have pain when the system isn't working. Somebody with longer-term multiple sclerosis can have contractures because if they have weakness over time, so their muscles aren't strong enough to fight the spasticity, and the spasticity overpowers their muscles, they can have a contracture as a result of it. Sometimes you'll see tremors, which is different than ataxia because tremors are subtle, slower movements, where ataxia is a little more jerky. See a lot of fatigue with MS. That is a big factor. So energy conservation is really important. Respiratory problems, are going to be more related to endurance, fatigue, not as much a respiratory like you see with ALS, but you can have the muscles in the neck that are affected, and so therefore you'll have dysarthria and dysphagia. So dysarthria is the speaking clearness, and dysphagia is swallowing. Someone with multiple sclerosis, if they have the different types of impairments or the lesions that are in the muscles that control the bowel and bladder, you can have somebody that has a difficulty with emptying or over emptying. So if you think about all of these, the sensory tracts can be affected, and somebody can have vertigo or dizziness, and visual. So those are a lot of different areas, and when you're looking at assistive technology, have to be really aware of how that individual is responding and asking a lot of questions about how they're doing. I mentioned earlier about the cognitive changes. So you typically see someone with multiple sclerosis has difficulty learning, short attention span, short-term memory problems, and you do see some problem-solving deficits. Because it is a over time and a very slow over time, you see a lot of masking of these areas, and sometimes they get interpreted as behavior. So you just need to be aware that multiple sclerosis has that cognitive piece.
And Teresa, we have a quick
weakness,
question.
Is that the weakness? I just looked over.
Okay, perfect.
You know, we actually had a grand rounds this morning on ALS, and they were talking about symmetry. Typically, I don't see a one-sided weakness in multiple sclerosis or ALS. They said they're starting to see some one-sided weakness with ALS that I have not heard before. Typically with multiple sclerosis, it's going to be symmetrical. So they're going to have bilateral weakness presenting throughout either maybe both arms or both legs. And then, you know, if their dominant hand is, you know, weakened, sometimes people just try to use bilateral, but I really see it more generalized. So there's the cognitive piece. There's also a psychological piece. So you do see euphoria, which is unusual happiness. You also see poor judgment, denial, and depression. You don't see a lot of like the tearfulness that you see with a stroke. Somebody said they can't hear me.
I can still hear you.
Okay. But these psychological changes, so if somebody is not adjusting, you know, the denial, but if they're not remembering things and they realize they're not remembering things, and that can lead into some of the depression. So applications for assistive technology, we see a lot of ambulation aids. We see manual and power chairs. Some of the studies that come out are really looking at the coordination impairing manual wheelchair mobility. And a lot of times we'll jump right into power for that conservation, and we don't typically have difficulty with funding to get power, but it's more acceptance of the individual ready to be seen or ready for their lifestyle to manage power. Power assist is becoming more common with a lot of different diagnoses that aren't ready for the big power chair, but really can't push the manual. You just need to be aware if you're in the States and you have a funding restriction. If you're in the private sector, I should say, some plans will require use of a manual chair for a year before they will do power add-on, as opposed to get you right into a scooter or power chair. So we tend to always, you know, early on, I don't always see them. And then the Assistive Technology Center for ambulation aids, usually when they're coming to me, they're ready to rule those things out. But having the discussion of their readiness for mobility, and then making sure their cognitive components that you have shown that they are safe in whatever power that you select. Positioning is important because they have the sensory loss. You always want to make sure that you get that nice stable base of support. The piece with multiple sclerosis is that even though they have sensory loss, they still have sensation. So being able to make sure that they're receiving the pressure management, but they're also tolerating being able to sit in the cushions. The one that is shown on the right is one of the J series, and the J series cushions that have a fluid in them are really good as far as skin protection, but some people that have good sensation feel like they're sitting in sand and they don't like that real solid feel. So that's why trialing equipment becomes really important, even having them sit on the cushion while you're doing some of the evaluations. Other AT for multiple sclerosis is self-care devices. We always look at the bathroom and what they need to help maximize their independence with grooming and self-care. They tend to benefit from some of the sensory and vision adaptations. A lot of these individuals are still working, and so you're helping them maintain their work. So they may need some adaptations with computer access and worksite and architectural mods. Later in the disease process, if they have a very severe dysarthria, you can look at some of the alternate communication methods. So I mentioned a little bit about ALS earlier. So ALS is amyotrophic lateral sclerosis, and you also hear of this as Lou Gehrig's disease. What this neurologic condition is it's a disease of the nervous system that specifically controls muscle movement. So in ALS, the motor neurons, which is the nerve cells, are gradually lost. So as the motor neurons are lost, the muscles they control become weak. So with multiple sclerosis, the channel that the neurons travel die, but with ALS, the actual motor units die. So the motor units die so that there's no signals going into the muscle, and then that's when the muscle stops functioning. You typically see wherever trying to think of how to simplify this, wherever you see the onset. So right here, let's say it's a higher onset. So it's the motor units are presenting up, let's say up here, then that tend to be like a bulbar onset. So a bulbar onset is going to be more oral motor, but they might have use of limbs, and we'll get into that in a little bit. But let's say this picture down here, the nerve cells die, you're going to see more typical motor. So the two camps with ALS is sometimes people end up losing their speech and their swallowing and their breathing first, but motor, they can still write what they want to say, they can still walk, they can still have motor function. And then the other big camp is where people have loss of all motor function, but can still talk and swallow, and then eventually they lose that. So the important thing is that the ALS looks at the muscle movement. So typically you don't have bowel bladder, you don't have systemic issues, it's all motor. And so that's where the word locked-in syndrome sometimes is referred to. So I mentioned that Lou Gehrig's disease, and I think it was the 30s. I'm going to test myself because I just had a grand rounds on this today. And so Lou Gehrig is the primary person that they understood what was going on, and they named it after him. You also hear motor neuron disease. If you are working with a client and you're working with a team, a lot of times it'll just say motor neuron disease because the person has not yet been diagnosed with ALS. So in the private sector, that can give us some headaches because we need the ICD-10 in order to get funded, but the person hasn't progressed to get that. So really depending on where you're at and understanding where the person has been in the diagnosis process, we used to see people kind of end of life where we were rushing to get the equipment and they may have only had a year with the equipment. And now we're seeing them on the opposite very, very early, and they're still walking, and we're trying to help prepare them for that equipment. So you may see motor neuron disease instead of ALS. ALS is just the most common form of it, and they all present very similar. So it is progressive, and it affects the uppers and the lowers. There is no sensory loss, so it doesn't attack the sensory system. I'm trying to look at the questions. It's diagnosed through an EMG. And so a lot of times the individuals will have symptoms for a couple of years before they're actually diagnosed. And that last slide there says typically fatal 2 to 5 years. You will see literature that says 2 to 5 years from diagnosis. And you will also say 2 to 5 years from first signs and symptoms. So 3 years is a pretty consistent timeline. And my clause on that is if they don't get a vent. If somebody chooses to get a vent, the vent is keeping them alive, and they can live 10, 15 years with the vent. Typically, the respiratory system is what is the cause of death for most people with ALS. It is higher in males than with females, and it is higher with Caucasians. So they really don't know. They don't know what causes it. There's a lot of theories. I'm super proud to say that one of the neurologists that we work with has narrowed it down to a gene. And so, you know, what is this, 2019? And we are so smart and have so many amazing scientists. And it's just such a tricky, bizarre diagnosis that they don't know what causes it. They do genetic testing. People can choose whether they want to have genetic testing or not. And of the people that get the genetic testing, only 5 to 10% are considered a familial track of it, so that it isn't inherited. So then we do a lot with genetic counseling and help them understand, okay, do you want to get tested? And they interview the whole family, because if the person chooses to get tested, it is familial, then there's an increased chance that they may have passed it on to their children. So we usually bring the whole team in, and you'll see families that are adjusting really well and ones that are just in shock because it moves so fast. So if 5 to 10% are familial, that means that 90% there's no known cause. No family history, no genetic component. Again, there's theories that sometimes we blame the environment, all the chemicals out there, but they really don't know. And I've never heard it to be an autoimmune similar to multiple sclerosis, but it's just something is attacking all those motor neurons. So question, but unlike Guillain-Barré, over time, for the person on the vent, this does not go away. So to your point, if they go on the vent, they are on the vent until other major organs failure. Yes. And, you know, you'll see them get a infection, or they can have a pulmonary embolism. So I guess the reason I say that is that sometimes I hear that, oh, they've beat the disease. Well, the vent is keeping them alive. And that's awesome, because I know a lot of amazing people that have gone that route, but they're still very locked in. And then we have to make sure that we're providing the support for the equipment and the supports for the vent coming around. But yeah, this does not go away. Whereas, I don't even know if Guillain-Barré, we talk about that, but like Guillain-Barré is that, we'll just do real quick since you asked. So Guillain-Barré is something attacks the system, but then leaves. And so then the system heals itself and the person recovers. Multiple sclerosis, it continues to attack that track of myelin over time, and we can't seem to figure out how to stop that demyelinization. And then with ALS, we can't figure out how to stop those motor neurons from dying away. Kind of cool. Any questions on that? This is where I start talking to myself. So I like showing you the picture with the body to show you the bulbar versus muscular. Those are the two that I talked about. So the bulbar symptoms begin in the motor neurons for cranial nerves, and it is more rapid. What I struggle with as an assistive technology professional is if the person is moving fast and you see them early and they're still walking, we're putting someone in a power chair that's still walking. So I have a discussion with the family. This will conserve your energy. You don't have to be in it all day. You can use it as a dosing. And if you're going to go to your kid's school and have to walk a long distance, and you use the power mobility during the day, and then you can use your ambulation, later. So you really have to help them understand what their choices are. But in my career, seeing them late versus seeing them early, it's always better to give them that equipment that's going to make their quality of life so much better. So with the progressive muscular atrophy, which I think is more typical that you think of with ALS, it is a little bit slower than bulbar onset. And these people may have had back pain. We see a lot of carpal tunnel. People have like carpal tunnel syndrome or surgery. And so they've had like surgery on their wrist, or they've had back surgery, they've had stenosis, and then nothing gets it better. Then all of a sudden you see the flare up of their muscle starting to be destroyed. And so that person, it still moves fast. You're talking about a 3-year window, but it doesn't move as fast as the bulbar. And then the third one that I have not talked about yet is ALS with dementia. We're learning more about this, and if it is more in the, I'd say not only brainstem, but if the oh my gosh, I'm losing my words. Okay, I'm going to go back to get my words. Where the motor units die. So where the motor units die ends up not being in the body here, but it's up in the brainstem, and so then you end up having more of a dementia onset. And those I don't think are as well known, and sometimes, a lot of times you're going to see a muscular atrophy also, but you're going to see this progressive dementia moving pretty fast. So if you start seeing, like with the power mobility, them just not making good decisions or not following through, then you may want to go back to the treatment team and find out what's going on. So overall, you're going to see a lot of weakness, with muscles most used. So like with the legs, you're going to see the weakness in the quads or the hamstrings. With the upper extremity, you're going to see the hand weakness. You can see abnormal muscle tone, and you see, they're calling it spasticity and clonus, but you see a lot of muscle fasciculations. So you see a lot of jumping with the muscles, and that is a common sign of what you see with the MS. Functionally, it doesn't get in the way as much as a muscle tone that you see with like a spinal cord injury, but there could be some coordination imbalances with that. Joints tend to get stiff mainly because they're not being used as much, and you have that limitation, that overall really poor endurance. And we've already talked about swallowing and breathing. Swallowing, they will mask it, and usually you can hear the dysarthria in the talking and the slurred, and you should always ask them about the swallowing. Because the respiratory tends to be where their demise is, we want to make sure we catch any swallowing difficulties so they don't aspirate and their fluid doesn't go into their lungs, which can be really difficult. Sensation is intact also, just like multiple sclerosis. So we need to make sure that we're considerate of equipment that they can tolerate for long periods of time. And if there's not dementia, there is no impairment with cognition. So because this is a very fast, rapid progression, we tend to go right to power. I will talk to family about what resources they have. Ultimately, we would want everyone to have a manual chair and a power chair. The ethics or challenge or frustration is that you see somebody put all their money into, a van and home adaptations and ramps and equipment, just a lot of resources in a short amount of time. So if they really can't manage that power chair, but they have places to go, then we'll talk to them about the manual with the power add-on and positioning. We also use a lot of loan closets. The ALS associations, there's national and local associations. We have a lot of really, really good support. So maybe talk to the families about using their insurance for the more expensive equipment and maybe trying to get some loaner equipment. The other thing that has been easier with this population is tapping into like the funding. And so right now we have a lot of good resources. Steve Gleason, it's Gleason. He is a former New Orleans Saints football player, and he was diagnosed with ALS, and he has an amazing nonprofit, and he will fund a seat elevator. And when we go into the powered mobility, the seat elevator is what allows you to raise up to be at eyesight with someone, at eye level with somebody else. There's also United Spinal Association is offering seat elevators and power add-ons. So working with the team and exploring different resources. For the clinicians on the line, a lot of these organizations want to hear from us. They don't want the vendor to initiate it. So if the vendors on the line can teach your clinicians about what's out there, and together you can help educate the consumer and see what additional resources they can get before the equipment is funded. Positioning is important because we want to make sure we're giving them that base stabilization for maximal function. We want to make sure transfers are safe for the caregivers as well as for the consumer. And that's where the seat elevator, so you're always going downhill, is really valuable. Even though they have good sensation, they can't do pressure management or pressure relief. So we want to make sure we've addressed that. Sitting tolerance we talked about, and being able to move in and out of positions. This population benefits from lots of different assistive technology, and making sure that we're adjusting their access method as they progress. So if your individual lives pretty far from you and you need to plan on getting them back for updated justification when they can't use joysticks and they have to go to alternate drive, that is something that you should plan out and help them be ready for. Even though they know it's a progressive disease and we don't have difficulty jumping into power right away, we do have difficulty in the private sector funding alternate drive while they still have joystick. The theory is it's easier for them to learn the alternate drive before they have to use it, but that is an area that we've not been able to win the battle on. I keep saying the private sector. The VA recognizes ALS as a diagnosis, a VA eligible diagnosis. So when we do have individuals, we will ask them if they have, ever served in the military. And some people may not have utilized any of their VA benefits, but once they realize that that's a benefit, it's really worth it to go and sign up, because the VA will fund power, manual, they will modify transportation, and they do a ton of home modifications. Other options for technology, if someone wants to go to a vent, we need to make sure that they have the vent tray and that the vent can tag along with the chair. Interfacing technologies, if someone has limited movement, we can pair the phone with the chair, and then they can access through their joystick or with eye gaze all of the technologies. I do kind of not stalk, but I follow Steve Gleason. He's done an amazing amount of work for the industry, and he's a spokesperson with Microsoft. So if you want to Google him and see They just came out with an eye gaze power wheelchair, and he has used communication device for as long as I've been following him. And it's really interesting how he does speeches. He does his ability to have the interfacing is incredible. So it's Steve Gleason, Gleason, and his nonprofit is No White Flags because he doesn't want to give up. He did a documentary that was out because him and his wife, when he was diagnosed, I don't remember if his child was either just born or ready to be born, but he was really young. So they were doing a documentary thinking, oh, we want Rivers, his child, to know who dad is. And it ended up being a really cool documentary of how they've adjusted and survived with this horrible disease. So I've learned a lot from watching him. And I know that there's a lot of other really amazing people out there, but personally, I've learned a lot as a therapist with how he's utilized technology and equipment and how he's pushed the industry. Medicare wanted to rent communication devices. They wanted to stop purchasing them. And he went and did the Steve Gleason Act, and he got it all stopped. So he uses the eye gaze, a communication device. He uses the computer, the internet, everything. So when you look at this list that's up here, he's a good spokesperson for that. So now we're going to go into spinal muscular atrophy, and you'll hear that as SMA. So the definition, this is genetic. So it's a group of genetic disorders that cause progressive muscle weakness due to damage to the motor neurons in the spinal cord. It is progressive. It affects lower motor neurons. So you'll see paralysis of muscles, and you see lower than normal muscle tone. So you see hypotonic. Can you repeat that? Did you say he stopped the mandatory purchase of AAC? No, flip it. He stopped them from having it be rented. And now, because it was a Steve Gleason Act when Medicare was trying to just rent AACs. I might have said it backwards, sorry. But spinal muscular atrophy is 1 in 6,000 births. So because it's hereditary, it's caused by an autosomal recessive gene. So if there has to be a carrier in the father and a carrier in the mother. So with each pregnancy, the 3 outcomes, either you have 25% of a normal child, no kids, my kids aren't normal, but no neurologic damage, 50% that the child becomes a carrier, and then 25% that the child is affected. So it's really 1 out of 4 chances that the child is born with it or will present with it. There's these different types. So there's type 1, 2, 3, and then there's adult spinal muscular atrophy. So this goes through type 1 is called Werting-Hoffmann disease. So usually it's before age 6 months, and the child usually instantly has breathing problems, and it's pretty fatal within a year. So I work with adults. I don't get to work with a lot of these type 1, but they can be treated, and they can overcome some of the breathing. Type 2, you usually see between 6 and 18 months, and the life expectancy is dependent upon some of the breathing problems. Most survive into adolescence or young adulthood. With the awareness of the complications, I do see a lot of the type 2 coming into my clinic when they're transitioning into adulthood. And then type 3, which I've never heard Kugelberg-Weylander disease. I know you won't be tested on that, but it's always good to know the onset. So it appears after 18 months, and they have a normal life expectancy. So the thing with some of the spinal muscular atrophies, if families have like multiple births or kids back to back, sometimes they may have They might have 2 kids with it because they didn't realize there was a problem until the child was older. You don't see it as much in spinal muscular atrophy as you do in muscular dystrophy, but thinking about when the presentation comes on, especially if the parents are just carriers, they would have no awareness that this may be an outcome. So there's adult spinal muscular atrophy that begins after the age of 21, and you have a normal life expectancy. I saw a gentleman on Tuesday that had this, and it was just really interesting to me because it just caught me a little bit off guard because I don't see a ton of the adult SMA. Again, depending on where you're at, if you don't see a lot of neurologic, you might not run into them. They do have progressive weakness with the muscle wasting, definitely hypo, definitely low tone, and definitely low reflexes. So positioning becomes really, really important in bringing to them the environment and looking at switches and looking at proximally bringing things toward their midline. Obviously, we want to keep them independent. We usually see these kids get into power mobility, and depending on what type of spinal muscular, depends on some of the positioning. Because they have that low tone, we want to make sure that they have really good trunk support because they're growing. So you have a growing kid with low tone and gravity affecting it. So you're going to see some spinal asymmetries, and you want to push to try and get some really nice, good supported systems. Tilt becomes your friend. So helping them with uprights, not fighting gravity, and making sure they can do skin protection with pressure management. And, make sure they're comfortable and they can tolerate sitting long. Looking at equipment for what do they want for self-care. It's interesting as I've gone through my career, as a new grad young therapist and then progressing through to when I had my kids and now my babies are in college. But, that role of the parent, you don't tend to see as much ADL equipment as far as the independent self-care because the parent, it's you have to respect that role of they're wanting to do something for that child. But then you have to think about when they get to school, if they've done everything for them, then who is picking up? So that's an area that where you're treating the child and the parent. And I've really looked at that differently. And so when I've worked with the school age kids, I've looked at the classroom and, if they do need to use the bathroom or they do need to access clothing management or assist with getting their coats on, what is that basic ADL equipment that we can help with? The other ADL equipment is the bathroom equipment that we've already talked about. Electronic ADLs, we've talked about just the open industry of smart home hubs, apps on our phones, looking at the computer access, and proximally they're going to have, I would not say proximally, distally, they're going to have their hand function, but they just might not have enough strength to hold their arms out there. So we want to bring like lap trays and bring things to them. So now I'm going to look at the time. So this is about the halfway point. It is 8:15. I'm going to keep going till 8:30. So we'll break at 8:30, and then is my pace okay for everybody? Okay. Yes. Okay. So I'll keep going, and maybe we'll end a little early. Those are my last famous words. Okay. So think about it. We have had multiple sclerosis. We had ALS. We had spinal muscular atrophy. Now we're talking about muscular dystrophy. So this is also a progressive disease, and it causes weakness and loss of muscle mass. So if you look at this picture, I'm a big picture person. So with muscular dystrophy, it attacks these proteins. So you don't have the dystrophin, and because you don't have the dystrophin and it's attacking these proteins, then you end up losing the muscle cell membrane. And the muscle cell membrane is inside muscle fibers. So it's hitting it to the core of the muscle fiber. The multiple sclerosis was hitting that sheath. The ALS was killing the motor units. Muscular dystrophy is killing these proteins in the dystrophin. So characteristics that we see, again, it's progressive. It's a muscle disease. It is hereditary. I'll open my hand again. Okay. The most common is Duchenne's muscular dystrophy. Duchenne's is pseudohypertrophic muscular dystrophy. It's also an X-linked recessive gene, and that's why it primarily occurs in boys. Some diagnosed in children, others don't appear till adulthood. Sorry, I had to take a drink there. So here are the different types. I'm going to minimize my chat box, so holler if you need something. So there's different patterns of muscle movement in different ages where the weakness begins to appear. There's different rates of the progression, and the examples are what we have here. Duchenne's and Becker is where you have the impairments in the legs and in the shoulders, but you have preservation in the hands and preservation in the trunk. Emery-Dreifuss, you have impairments the side of the legs, and you have some of these shoulder muscles, but you have preservation in the hands and the trunk and the hips. Limb-girdle is essentially what you think of. It's the limbs and the girdle. So you have that proximal at the shoulders and at the hips. I always called this FSH, so fasciculoscapulohumeral type, and it is weakness in the shoulders. You see a lot of winging. You also get some motor impairment, but it's usually preserved in the trunk and hips, and you're going to have some lateral leg movement. And then oculopharyngeal, I have to tell you, I don't see a lot of these, but this is where you have impairment in the hips and then in the shoulders. So depending on how they present, is going to direct all the assistive technology. How is Duchenne's different from Becker? If you ask the neurologist, and if there's any therapists on the phone that want to add to this that work in a neuro clinic, they're very, very similar in presentation, but at the, I guess think about this, at the motor pool and at the firing in the muscles is where you see some different presentation and some of the subtle, more refined movements. I typically treat them very similar because with the assistive technology. But if I ask my friends in the neuro ALS MD clinics, they'll talk to you 45 minutes about the differences. For the purposes of our exam, Duchenne's, Becker are going to be the ones. I bet you guys see Duchenne's, Becker a lot, the most. Emery-Dreifuss, these kids are ambulating. You might not see them. And then the limb-girdle, what you see with limb-girdle is because they have this hip weakness and they have shoulder. So if you think about shoulder weakness, so they can't extend their arm to do a push-up for sit to stand, and then they have really weak hip flexors. So, Roel, I'll get your question 1 second. And so getting from sit to stand is so important to get your seat to height right. And so I had an individual that has had limb-girdle, long time, his whole life, and he was in his 50s, and he always had a chair at the seat elevator. Well, guess what? His insurance decided he no longer needed it. So we went through and quantitated his entire house was set up at a certain height, like his toilet, his tub seat, his in his kitchen, his chair. He had to sit at a certain height. So we measured his reach because he didn't have a lot of good extension. And then we also measured his sit to stand. And so we had to really defend the technology. So the difference between muscular dystrophy and spinal muscular atrophy is that spinal muscular atrophy is caused as a result of damage to the motor neuron. It is damage to the muscular. Yes, SMA is motor neuron. Muscular dystrophy is this protein with the dystron. And then SMA, we don't have a little picture of the SMA. So it is the motor neurons. So yes. Get back to where I was at.
And then there was a question about the oculopharyngeal, about impaired vision.
Impaired vision. Yep. Yep. So all the assistive technology for our vision, consumers with vision, is where it really comes into effect with the oculopharyngeal type. Has anyone seen oculopharyngeal? Anyone on in here seen that? Okay. So if you go back to that picture, the cause of muscular dystrophy is that genetic mutation, which is the absence or abnormality protein of the dystrophin. And the cause is that progressive destruction of the muscle fibers. And some forms are hereditary, inherited. And it's that, like the Duchenne's is linked to the X chromosome. So that just summarizes. Oh, you did? So Adrienne had somebody, it was mainly swallowing. Was their vision okay? I'll let her type while we talk. I can tell you that there's some really cool research going on that they've been able to demonstrate that they're able to get this protein replaced, and they're seeing a slowing down of the progression of it. Kind of gives me goosebumps as far as it's still in the research phase, but they're having some really positive outcomes with people that are receiving the medication. It's super expensive, but if you're near any big neuro sites, that is a big excitement in the field. It's not to the point where it's changing the assisted technology recommendations, but I just like to throw out my clinical examples. So, muscular dystrophy, all forms result in progressive muscle weakness, but there's different muscles that can be affected and different ages at which the symptoms come out and different patterns of the weakness and different prognoses. So essentially, it's this picture right here. Duchenne's has proximal muscles affected first, and then it goes distally, and then it goes respiratory and heart. Calf pseudotrophy occurs in 80%, and because it's progressive, it shortens the lifespan, and the kids are non-ambulatory about by age 12. Average lifespan is 20 years. You know, I think that's average. I do see them into adulthood. The thing with these kids, and when we get to positioning, if you think about it, they are ambulatory up to age 12, but I like these pictures. But they have weakness in their hips and weakness in their shoulders. So you see a lot of seeking stability, and you see a lot of arching and anterior tilt. So if you have somebody that's coming into your clinic that has strived for stability movement as they've gotten weaker and weaker in their hips, you start to see more overcompensation in their trunk. So we'll go over some examples when we talk about positioning, but as we're thinking about the medical diagnosis, it's starting because they have these trunk muscles that are strong, so their trunk is kind of overcompensating for the weakness that they have in their hips and their shoulders. And they don't have any sensory limits. any sensory loss. I just talked about that. So the muscular dystrophy also can have osteoporosis. Anytime somebody is having limited weight bearing, you're going to just have risk of limits with bone mass. Oh, look, this is what I was talking about. You see a lot of postural deformities and asymmetries. And so see how this person's arching. They're arching themselves. In this position here, it's a high guard. So you put your hands up for stability. If you think about little kids when they walk, when little kids are learning to walk, you see them with their arms up because they're gaining stability by keeping their hands close to them. So trying to make sure that you're helping them feel safe in a seated position is really, really important to try and get them so that they find that position of comfort. Their hand up. We're almost ready for a break, okay? Because of lack of activity, you can see obesity. You also can see some learning impairments. So if you're working in the classroom, you need to be aware of the technology that can help them. Okay, so we are at arthritis, and we are at 8:30. Were there any questions? Was it money and constant medical care that kept Stephen Hawking alive for so long? You know, I actually think about that. First of all, well, if anyone wants to take a break, we'll get back at 8:40. If you want to listen to that. If you look at him, I mean, he wasn't on a vent. Look at his position. I mean, his position was terrible. And it's probably he gained stability over time and then just didn't want any positioning. My theory, this is like, it's not researched and validated, but I almost feel like he had a PLS, which is peripheral lateral sclerosis, because a typical ALS does not have a long life expectancy if you're not on a vent. So yeah, I think it was money and I think it was constant medical care, but he didn't have the respiratory demise that you see in a typical ALS. I don't know if anyone else has a theory. Okay, so take a break. We'll be back and then we'll wrap this up. About 2 more minutes and we're going to get started. One more minute, and then we're going to get going. Okay, let's go ahead and get going to the second part. We are going to proceed with arthritis. So arthritis is an inflammation of one or more joints, and the characterization is swelling, pain, stiffness, and loss of range of motion. So if you think about it, you have a lot of pain and stiffness, and so then you stop moving it or you start guarding it, and then that's when you get your loss of range of motion. There's 100 causes of arthritis. It's also an autoimmune disease. The two primary are rheumatoid arthritis and osteoarthritis. A rheumatoid arthritis is a chemical imbalance that is immune modulated, and you can have an exacerbation and a remission. So what that means is you have flare-ups, and then for a while it'll just calm down. An osteoarthritis is degenerative and is usually traumatic. You see a lot of people with osteoarthritis that have a lot of comorbidities, and this may be one of many disorders. You also see that someone with real bad osteoarthritis that maybe has a fall and then end up coming into other complications. So because arthritis has a lot of joint pain, contractures, deformities, you end up having a lot of weakness because of the disuse. So the person hurts, they don't move, they get weak, and then you have a lot of muscle fatigue. And so arthritis really benefits a lot from assisted technology. The challenge is that as a standalone diagnosis, it's not always supported for some of the intervention or the equipment that is needed. And so I find that we try to, in our interview, try to understand if there's any other limitation that's going on, or try to get really good diagnosis for specific, like if there's degenerative disc disease because they have osteoarthritis. Osteoarthritis, OAA, can be warranted, but depending on if you're catching it early, you want to really make sure that you're specific on where that degeneration is occurring. Anything that you can do to reduce stress on the joints, with the RA and typing, and a lot of the adaptations for the environmental ADLs, kitchen, home management, a lot of these people are still working, and so you want to be able to look at what they can do for helping fatigue, so that if they get fatigued and then they stop doing more, it's just that spiral down. So mobility aids, you may not want them to be pushing a manual chair, even though they can push a manual chair. You need to be able to demonstrate in your interview and also in your assessment why this might not be the best option for them. And then you also want to really work into a lot of energy conservation techniques. When they have pain, you're going to have pain limiting behaviors or pain limiting positions. You want to really pay attention when the person comes into your clinic. What is their position of comfort? Because even if they have the range of motion, they still may need accommodation because they can't tolerate sitting in maybe an aligned position that would feel like it should be more normalized. The next group is amputations and limb deficiencies. So a limb deficiency definition is congenital or acquired loss of part or all of one or more limbs. So they're either born with it or they have a injury or trauma or medical condition like a flesh-eating bacteria that ends up requiring the loss of a limb. Congenital, they're called phocomelia and amelia. You will never see those definitions, and so those are just two different types of the congenital deficiencies. And acquired usually is going to be because of surgical. So what happens is that when they have to do surgery for the amputation, they're going to intentionally try to do for an upper either transhumeral or transradial. And so they're going to specifically try and hit certain landmarks, and then that, as a result, will help with some of the prosthetic use. Go ahead and mute yourself if you're back. For lower extremity, there is, you can have all the way up the hip disarticulation. I really get to see a lot of these, and the challenge with the hip disarticulation, it depends how much of the pelvis they take. So don't be afraid to ask for the medical report. If you're not a clinician and you're the supplier, it's really helpful to understand what anatomy is going on so that when you're looking at the different skin, the equipment. And if you are a clinician and you're not getting the records you need, don't be afraid to ask, because depending on with us, we see a lot of the hip disarticulations because of post-tumor. And so if you have somebody that still has part of the pelvis or not part of the pelvis, it's going to make a difference in your seating. Some of the hip disarticulations in the military are a lot of the blast injuries, and so you'll see bilateral hip dysartics. And we really have a lot of success with these individuals with getting them seated, not only in their everyday chair, but we're able to also get them in a lot of sports equipment and adaptive equipment. So it's pretty traumatic because there's a lot of loss, and then you're really looking at a very unstable, because you're losing that weighted part of the lowers. So hip dysartic or hemipelvectomy. I guess I kind of got ahead of myself. So they could, if the pelvis is there, it's just a hip dysartic. If they start to cut into the pelvis, it'll be a hemipelvectomy. So then with the lower extremity, usually, again, you have a transfemoral, or you hear that as above knee, or a transtibial, which you hear as below knee. And then depending on if there's a specific cause, you may see a knee disc articulation or a foot. So these may be because of a disease process, but typically you're going to see it more classified as you see on the left side here. The assistive technology depends on the limbs involved and the type of deficiency. The thing with prosthetic devices is it's that game if you're in the private sector. At the VA, you're not going to have any difficulty, and you have a lot less limits with getting concurrent equipment. But in the private sector, I like to get started as soon as I can with the wheeled mobility, because when you're asking for wheeled mobility, at the same time you're asking for a high-end prosthesis, sometimes you get pushback. If you have somebody that's been a chronic amputee and is coming to you for equipment because maybe they're struggling with wounds at the residual limb or tolerance of the prosthetic, you really need to look at your assessment and think of, when this person isn't using their prosthesis, where are they spending their time and what are they doing? And so that's where you can focus and not get too tied up in, but they can walk, but they're not always walking. We'll look at, you know, maybe nighttime ADLs if they need to get into the bathroom, shower, like what is their routine with and without their prosthesis. For the upper extremity, you see a lot of different things. The literature shows that if somebody doesn't get the proper training, you have a high abandonment rate with the upper extremity. The technology is totally amazing on what they can do now, but a lot of times the introduction of it is the phase and the timeline. So looking at the different residual limb and the terminal parts, I think is what they call it. So if they have a computer access versus if they're doing maybe bike riding, like I know someone that has a different terminal end for being able to hold onto the handle of his bike compared to everyday use for work use. So ask about if they have other devices than what they brought here, and ask when you're not wearing it, where are you spending your time and what are you doing, so that you can get the whole picture. Another one, so arthrogryposis multiplex congenta. So AMC, a lot of times it's just arthrogryposis is what you see. So arthrogryposis definition, it's a non-progressive contracture of one or more joints acquired prior to birth. So you typically see, this is a really classic presentation, and so they have contractures of, usually I see like definitely the elbows and the wrists, but they can move their shoulder. Definitely always see the knees, and then you see some of the different limited finger movements. So there's cognitively intact, there's sensory intact. They're usually pretty motivated, active kids that just have to find different patterns of movement. So it's non-progressive, but then you have limitations in all your affected joints, and you have weakness around the joint because the joint's not moving. Depending on the location and severity, so mobility can be a problem. Let's go back to the picture. I'm a good picture person. So if you think, if this kiddo can walk, but if he trips, he's not going to be able to protect himself if he falls. So sometimes when they do have the ambulation, you also need to think, though, are they safe? You know, are they a safe ambulator? And you also might think about, they may not be spending 14, 15 hours in the chair. Positioning is so key. We have a kid that we're working with that we essentially bringing everything to him. So you see how the hand is turned out? So we have the joystick right next to him so that he could toggle the joystick. And then we also are pairing as much as we can with the joystick so that he could use his phone and he can use his computer. And guess what? We got that Xbox adaptation. And so he can do gaming with all of his friends. So we're able to, this is kind of funny. He uses his left elbow for the input for that Xbox controller, which is the new one that has big area. And then we'll use the left for making the, I don't game, my kids do, but the different controls. What's the question? I saw something about proportionate.
Is the joystick proportional or other?
We usually get them in proportional. Usually they can have, and again, if you can get that throw adapted, so if you can shorten the throw of the joystick, we're usually getting them all in proportional drives. Let me get back to my slide here. And alternate access, and again, we set up a lot of switches around them. Osteogenesis imperfecta, those very fragile bones. So they have because of their fragile bones, they have a lot of fractures, and it leads to orthopedic distortions and short stature. What I love about this picture is even though she has fragile bones, it's not stopping her from living her life and getting out there. This is a racing chair. So as long as they have that stability and they have that safety, they can interact with the world. But they do have very fragile bones. You have to be very aware of protective positioning. And we usually get them into power right away because they're just not going to be able to tolerate manual. So then we'll look at their environment. What do they need to help get set up? Depending on what their range of motion is and what their muscle strength, we bring everything to them and always think in terms of low impact. Oh my gosh, are we at the review? Oh, don't look, don't look. So I think we're at the end. I was talking really fast. So it is 9 o'clock. I'm going to shut this off and then go to the poll. Before I go to the poll, you guys are good at jabbering questions, but do you have any live questions for me?
You guys can unmute yourselves to ask, and if you can't unmute yourself, put something in the chat because I had to manually mute some of you.
Let's do the test. We'll keep it open. I was going to say we always end up wanting to shut it before you guys are ready. We'll keep it open for maybe 6 minutes and see how many submissions we get. So after you've done with the question, if you have any, or done with the test, if you have any questions. You can't see the test. Can others see the test? The test is blank. If this is Marisa Quarter, I can see the test. Okay, thanks. It doesn't matter if you, I see the question for Olga. It doesn't matter. We're not checking on who gets it or not. The test is for you to test your knowledge and also to help us know if we taught it in a way that it was able to translate into you guys getting the right answers. I don't know if it'll let you submit again, but if you want to try. So we have 43% submitted. Once we complete the course, how long do we have before we take the final? It was in the preparation slide yesterday. Let me double check, unless Heather knows off the top of her head. I feel like it's a week.
Yeah, I think it was about a week.
I'll look it up. It says you'll be emailed a link to the course email and post-course assessment, and received within 24 hours of the last class. Watch for email. Sometimes it gets into spam. So less than a week. Okay, we have 76% submitted. So I'm gonna 30 seconds and then I will close. I'm gonna say 15 seconds. Oh, how long do you have to complete it? You know what? Maybe that was the week. Maybe you had a week. Let me go back to my. It just says you have access to the course materials and recordings for 60 days following the last session. So Michael, you want to know 2 years for the COF certificate? Do we have to show up testing site? Are you talking about the ATP exam? The ATP exam is at the testing.
It'd be easier to ask you.
Okay.
When we did the COF, the Certified Orthotic Fitters class, it was a week long. And then they gave us a big book and basically asked us or told us, you know, we had 2 years to take the test. And then we had to show up to a H&R Block facility where we got patted down basically and made sure we didn't have any electronics on us. And then take the test there.
Was that test you took at the exam place like a cert test? Like a certification?
Yeah.
Yeah, this is a preparation course to get you ready to take the actual ATP cert. So you would sign up for the ATP exam completely separate from this class. And this class, they like you to do the course eval so that we get feedback on our teaching style and content. And then you do a post-course assessment. And then your post-course assessment gives you a link for a practice exam. Once you do that practice exam, it can say, hey, you better go review these things or you're pretty good. And then at that point, you can gauge when you want to sit for the ATP.
Okay. So it's kind of similar.
Does that make sense?
Yeah.
Yeah, it's just that there's a separation. Like there's not a link between when this is and when the ATP. Somebody said they're taking the ATP like a week after this course ends. So kind of using this as a dry run, but typically that's not the case.
Okay. I was just curious because, yeah, we did the same thing when we did the online we had to take a test immediately afterwards. But then when we went for the actual certification, we had to go to like an H&R Block and all that stuff.
Yeah. Okay. Yeah. This is just a sample to help you gauge on your preparation.
I'm with you.
Okay. So I'm going to go ahead and close it. And then I'm going to review it and I'm going to share it. Wow. You guys did really good. So a key difference between a spinal cord injury and multiple sclerosis is the correct answer is multiple sclerosis is progressive. So this is where some of the tips for test taking. So key difference between spinal cord and multiple sclerosis. Read each of the answers. Multiple sclerosis occurs in adults. Well, it could, but it doesn't have to. Multiple sclerosis causes muscle weakness. Well, it probably, could. Spinal cord injury results from damage to the nervous system. No, it's not the nervous system, it's the cord. Multiple sclerosis is progressive. Yes. So Progressive is what the difference is, the key difference. So go back and ask what the question is. So the question is, what's the difference between a spinal cord injury and multiple sclerosis? Because a spinal cord injury can also occur in adults, and a spinal cord injury can also have weakness, but a spinal cord injury is not progressive. Does that help you guys, give you some tips on when you take the exam on how you want to read the question, read the answers, and go back and say, what are they asking me to do? Anyone have any questions that may not have gotten it right? Okay, I'm going to keep going. What is a likely pathology or symptom seen in an individual with muscular dystrophy? So the answer is muscle weakness resulting in postural deformities. So 82, you guys did really well. I mean, you got a high percentage. So going back, what's the pathology or symptom in an individual with muscular dystrophy? So difficulty with processing language, no impairments with language, spasticity due to neurologic damage. No, muscular dystrophy usually doesn't have spasticity. Non-progressive loss in functional movement. The muscular dystrophy is progressive. So that is why the right answer is muscle weakness resulting in postural deformities. Third question, which of the following is an important differentiation of arthritis, arthrogryposis, and osteogenesis imperfecta? So what's the one important differentiation of those three? They're all orthopedic. So if you go through, they aren't neurologic, they aren't progressive, and they are static, meaning that, again, they're not progressive. So that's why the common theme in them is they're all orthopedic, at 91%. Okay.
And Teresa, there was one question about, have you ever seen pediatric MS?
No. Nope. I have seen rare form of teenager, like 16, 17, and we all kind of go, oh my gosh, you never see that. You know, you may be an 18-year-old, but you really do see it in adult. You do see an adulthood. Never peds. I don't know of any peds cases. Ever seen peds? Nope. Thank goodness. Okay. Well, I've bought you guys 25 minutes of your evening back. So I am happy to stay here and answer any questions. And we are going to convene again on Tuesday, October 29th at 7:30 for assessment and delivery. You get one more night of me, and then you get Miss Heather. Okay, so I'll stay on, and thanks everyone for their attention and great questions.
Hey, this is Mike again.
Yeah.
Okay, so I'm a little confused and I've been super busy with work. So this is the prep course. Yeah. And then we get the prep course. Then what is the next step after that? After we pass the test?
So what is your readiness for the exam? Do you feel pretty good about where you're at in your preparation?
This part is, I mean, there's some stuff that I'm not, 100%, but, I like that because, number one, I'm always willing to learn.
Yeah.
But my ultimate goal is to get an SMS.
Okay. Yeah.
So
if you feel, so this course goes over all the domains that are going to be tested. So if you take that post test and you do pretty darn good, I think you're ready. You could go ahead and apply for the exam. Have you gone through and started gathering your materials?
Okay. Yeah, I mean, I've got
your reference, or what is it? Your work verification, your reference.
Yeah, I'll get all that. That's not going to be an issue. It shouldn't be.
Yeah.
The only problem I had was the DME company that I originally worked for. Both parties passed away, but you know, Charlie said
Yeah.
and he said that's not going to be an issue because I have power wheelchair paperwork from 11 years ago.
Yeah, they're really good at helping you. You know, the intention isn't to trick people. It's to make sure that they're not getting in before they're ready.
Right. Well, I was just happy. I was looking at the qualifications and I'm like, okay, 10 years, high school diploma, orthotics, power chairs for 10, 11 years. Sounds good.
Yeah. You know, if you don't do a lot of AAC computer access, you might want to brush up on those. That book that they give you, you know, take a look at that. I think, you know, the speech therapists have to really brush up on the seating. So gauge of this content, what you feel that you need a little more polished on. And if you've been practicing it, the warning about somebody that's been practicing for a while is slow down when you read the test questions.
Right.
Because sometimes we get ahead of ourselves and we're not in an environment where we're test taking, you know.
Yes.
So when I've talked to people that failed the first time, and I actually had someone on this course that I did before that kept saying, but I don't know what to do. I don't know what to do. And I went back and talked to some of my colleagues that were suppliers, and the biggest thing was don't rush through it and go back and make sure you know what that question is. And for myself, that I tend to do that. I rush through tests. So that made sense to me. And, you know, if you're been in seating for 10 years, that's not going to be the part. Make sure that you have all the areas of domain covered.
Okay. Well, thank you so much for your time.
Absolutely. Have a great night.
You too.
Hi, this is Marisa Corder. Are you still there?
Yeah.
Okay. I just wanted to ask, you said something about them retaking. So are you able to, how many times are you able to retake the test? Is it, you know, if you don't pass it the first time, you get a second time? Yeah.
Let me look that up. Heather, do you know?
No,
I feel like it's 2 times. It might be on the Resna it might be on the Resna. Let me go to the Resna website.
Because from what I was reading today, my understanding was after this course, you've got and there again, I can go back and read it. You have 90 days to take the ATP certification.
No. Why don't you reach out to Charlie? But I've not heard that at all. It's not a connection. It's a prep. Some people start with this course and realize, oh my gosh, I've got a lot that I have to do. And then they start mapping out their what's it called? Their training. Yeah. Here, about the exam. Whoa. So there's a whole ATP section of the website.
Okay.
Oh my gosh. About the exam, apply for the exam, eligibility, readiness tool, candidate, exam outline, exam prep, scheduling it. There's a whole section. Why don't you take a look at that and then reach out to Charlie. If you do between now and Tuesday find out that there's a timeline, reach back out to us because I have not heard that. Heather, have you?
I have not. No.
Okay. I'll find out. I'll go look at these resources, and I'll ping Charlie if I don't find it in there.
Okay.
Thanks,
Thank
guys.
you.
Thank you so much. Have a good evening. Okay, bye-bye.
Olga has a question about cerebral palsy.
Yeah.
So she says, cerebral palsy, so the CP tone can be high, low, or rigid. Is athetoid CP considered a tone problem?
Let me think about this. CP tone can be high, low, or rigid. Is athetoid. So in the text of describing the tone, and you might want to unmute yourself and we can talk, but I would say someone with an athetoid has increased tone, but it's their movement. It's more like, it's not ataxic like a rigidness. It's more like a wormy type of very fluid discoordination. Because if you have low tone, you're like a noodle. You don't have any movement. It's definitely not rigid because it's real squirmy, like movement, kind of like a dancer, you know. But a high spasticity, like a quadriplegic spastic CP, it is definitely more along the rigid. My final answer is athetoid. It's more of a movement pattern than a tone. How'd I do, Olga? And tell me the context of what you would want to use the information for. Or just trying to understand it. Differentiate for the exam. Okay. I'm just trying to think of, so think of like if someone has a keyboard, they might want a key guard if you're an athetoid because you might be hitting a bunch of the different keys. And when we get into some of the different technology in the further exams, we can go back and apply some of these if you want to get some more differentiation of it. But yeah, I would call it more of a movement pattern, but anything with a higher velocity is going to be a higher tone. But when we talk about tone and spasticity, we usually talk about like more of a increased firing rather than the movement pattern. Ataxia and athetoid is like the movement of it. Okay. Any other questions for anyone? Okay, Heather, I'm going to go ahead and stop recording. Does that sound good to you?
Sounds good.
Okay. Well, I will see everybody on Tuesday.